Hey everyone, it's Lindsay here again, all makeup free and moisturized and all ready for bed. So I haven't read on this channel from an actual book for a little while. I've just read mostly like stuff from textbooks and some MCAT materials and everything, really just study stuff. So I wanted to go ahead and get back to reading this book. I have read it a little bit on my own without filming. You can probably tell I've made a little bit of a dent in it, but I am really enjoying this book. I'll probably do an in-depth review of it once I'm finished with it, and I hope the rest of you are enjoying hearing it as well. I think it's very engaging and interesting. Really enjoying it. It's such a nice night to just lay in bed and read. It's raining outside, which it usually is here in London, but yeah, the rain's coming down and I'm just here in bed ready to go to sleep. So let's read a little bit first. Okay, so getting back into, if you haven't seen the first parts, this book is Pushback by Dr. Amy Tutor. She's an obstetrician and gynecologist, so just jumping right back into it. How does an epidural work? Epidural anesthesia and its close relative, spinal anesthesia, are techniques in which the nerve roots of the spine are numbered with a local anesthetic. The effect is similar, and the medications are similar, to numbing your mouth with Novocaine in preparation for dental work. However, the numbing, I don't know how good of an angle this is. Thought it would be nice to lay in bed and read, but I don't know how good it is. However, the numbing effect takes place over a much larger area, leaving you without sensation below the waist. Your labor continues, but you don't feel it nearly as much. Epidural anesthesia is administered through a tiny catheter placed in your back, overlying your spine. The catheter provides a continuous flow of anesthetic that bathes the nerve root of your lower body as they leave the spinal cord. Usually you receive continuous and complete pain relief. Sometimes, however, not every nerve root is reached by the catheter. In that case, you may have a window, a small area that is not anesthetized. This can be very disconcerting, but it can actually be fixed by repositioning the catheter. Just as there are risks to using Novocaine for dental work, there are risks to an epidural. No doctor would deny this, but the actual risks of an epidural are very low, and most side effects are easily reversed. For example, epidural anesthesia can anesthetize the nerves that control the diameter of blood vessels and thereby regulate blood pressure. After an epidural is administered, you may experience a temporary drop in blood pressure, which may decrease blood flow to the baby. This could result in a temporary drop in the baby's heart rate, or bradycardia. The drop in blood pressure can be corrected with extra intravenous fluid or medication if necessary, and the baby's heart rate will recover. Spinal anesthesia works on the same principle as epidural anesthesia and was often used in labor before epidurals became available. Because of its distinct characteristics, spinal anesthesia is now considered more appropriate for C-sections and forceps deliveries than for labor. Spinal anesthesia requires the injection of anesthetic directly into the space surrounding the spinal cord. It is administered in the same way as an epidural, but no catheter is left in place. Because only a one-time dose can be given, the amount of anesthetic injected is relatively large. This results in quick action, 5 minutes versus 15 minutes for an epidural, and dense anesthesia. The spinal anesthetic almost always affects motor nerves, and therefore muscle power significantly. Most women lose control over their legs and cannot push effectively after a spinal anesthetic has been given. These qualities present serious disadvantages in labor, but make spinals especially useful during C-sections. They work fast, allowing for major abdominal surgery with no pain. Best of all, the mother is awake and aware throughout the surgery. An epidural can also diminish muscle control. That's why anesthesiologists often substitute some of the anesthetic in epidurals with opiates. The combination provides effective pain relief but preserves muscle control. A more significant complication of both epidural and spinal anesthesia is spinal headache. When the membrane surrounding the spinal cord is pierced, accidentally in the case of an epidural and deliberately in the case of a spinal anesthetic, there is an approximately 1% chance of developing a severe headache due to leaking of spinal fluid. The headache will go away by itself, or if it lasts for a while, it can be treated with a special injection of the mother's own blood at the original site, sealing the leak. This is known as a blood patch. A spinal headache is not harmful, but it is very unpleasant, so it is something that women should consider before choosing epidural anesthesia. Childbirth wouldn't hurt if only. Many natural childbirth advocates subscribe to the if only school of pain management. They believe that you would not experience childbirth as agonizing if only you were more knowledgeable about childbirth, if only you hadn't been socialized to believe that labor is painful, if only you had eaten right and exercised, if only you had hired a doula, if only you hadn't had an IV and/or electronic fetal monitoring. To understand why the if only school of management is wrong, not only in their understanding, of pain, but also in their claims about what can and cannot cause pain. It helps to apply their claims to other forms of pain. Consider gallbladder pain, a classic form of visceral pain that occurs when the gallbladder attempts to squeeze the bile, but cannot do so because the duct is blocked by gallstones. Would a patient in the midst of gallbladder attack have less pain if only she was more knowledgeable about gallbladder attacks? If she hadn't been socialized to believe that gallbladder attacks are painful? If only she had eaten right and exercised? If only she had better support? If only she hadn't had an IV and/or electric blood pressure monitoring? The answers, of course, are no, 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 and no. Why are all the answers no? Because gallbladder pain arises from the contractions of the gallbladder attempting to push out a gallstone and is transmitted to the spinal nerves and thence to the brain. The pain impulses from a gallbladder attack aren't modified by knowledge, socialization, diet and exercise, nursing support, or the presence of basic medical safety measures. There's no reason to expect that they would be modified by these factors. Similarly, there's no reason to expect that labor pain would be modified by these factors either. No woman or man should or would feel guilty about suffering severe pain during a gallbladder attack, and no woman or man should or would feel guilty about treating that pain with pain relievers. Similarly, there's no reason to feel guilty about experiencing or treating severe pain during labor. How about somatic pain? Consider the pain from a broken bone and ask the same questions. The answers will be no once again, and for exactly the same reason. Just as knowledge, socialization, diet and exercise, nursing support, or the presence of basic medical safety measures would not be expected to modify the pain of a broken bone, they cannot be expected to modify the pain of crowning and birth either. No one should or would feel guilty about suffering severe pain from a broken bone, and no one should or would feel guilty about treating that pain with pain relievers. Similarly, there's no reason for a woman to feel guilty about experiencing or treating severe somatic pain during birth. The majority of mothers who give birth around the world every day have no pain relief available to them and must endure unmedicated childbirth. They don't consider themselves empowered by the pain. The glorification of unmedicated childbirth is reserved for those privileged women who have pain relief available to them and therefore can make a choice. The achievement for natural childbirth advocates comes in the refusal to have an epidural when it is easily available. But just as the pain of childbirth is no different from any other form of pain, and just as pain relief for childbirth is no different from any other form of pain relief, refusing an epidural in labor is no more an achievement than refusing Novocaine for a root canal. In other words, it is no achievement at all. Severe pain is disempowering. Many natural childbirth advocates insist that epidurals are disempowering because they limit movement and sensation. Yet there are even more women who find them empowering because they eliminate pain. Dr. Jane Marie Maher at Australia's Monash University offers a very different way of conceptualizing pain and empowerment, one that resonates with most women. When we are in pain, we are not selves who can approximate rationality and control. So with this approach applied, it can be argued that epidurals, the most effective form of pain relief, give women control over their bodies and control over their behavior. They allow women to represent themselves to others in the way they wish to be seen, instead of forcing them into a non-rational space. While some natural childbirth advocates value the ability to move above all else, and therefore consider foregoing an epidural empowering, most women value the ability to control their own bodies and control the way they behave. For them, pain is disempowering because it robs them of the control they value and the ability to articulate other desires. The bottom line is that there is nothing inherently empowering about pain or pain relief. Consider Gabriella's story about her desired unmedicated birth of her second child after her first birth with an epidural. I got my natural birth, and it was supposed to be so much better. Well, I was sold a bill of goods. The baby had a smoother start to breastfeeding, but that's more likely due to the fact that I had 2 years of successful breastfeeding experience under my belt. I knew what I was doing. I did initially recover quicker, but that was probably because the labor was so short, and again, prior experience likely had a hand too. But you know what? The pain I endured left me traumatized. Like postpartum depression, post-traumatic stress disorder traumatized. It's common knowledge that natural birth means no PPD. Well, with my first, I had just a touch of baby blues. With this birth, I was hit by horrible, debilitating PPD. He is 15 months old now, and I'm only just starting to feel normal again. Here's the kicker. When my PPD got really bad, I contacted a hotline, both for someone to talk to and to find further professional help. The lady I spoke to on the hotline was a midwife. I told her the story and how traumatized I was. She seemed genuinely confused as to how I could have gotten PPD when I had a natural birth, because it goes so against the narrative. She also didn't get why I was upset about my birth experience. It was a dream, quick and completely intervention-free. Interventions are the traumatizing stuff, not unmedicated birth. Ultimately, the decision concerning pain relief in labor depends on what each individual woman values and wishes to control. Wanting to move in labor is no more or less important than wanting to be comfortable in labor. The benefits and risks of epidurals. Epidurals have changed labor by making it much less painful and much less feared than ever before, but natural childbirth advocates insist that the risks outweigh the benefits. The problem is that many of these purported risks have been shown not to exist. For example, natural childbirth advocates claim that epidurals increase the likelihood of C-section, but that's not what the scientific evidence shows. Multiple studies address this issue. They show that epidurals do not increase the risk of C-section. A Cochrane review published in 2011 included 38 studies involving 9,658 women. The authors found that epidurals had no statistically significant impact on the risk of C-section or neonatal well-being. Epidural anesthesia did increase the risk of having a vaginal delivery, assisted by obstetric vacuum or forceps. Furthermore, a 2014 Cochrane review of 9 randomized controlled trials involving 15,572 women found that there was no increase in C-sections, vacuums, or forceps delivery rates between epidurals given early in labor and those given later in labor. Nonetheless, natural childbirth advocates continue to peddle the falsehood that epidurals increase the C-section rate. N.C. Gore, writing for the Lamaze blog Science and Sensibility shortly after publication of the 2014 Cochrane review, still insists that, at the very least, we cannot assure women with confidence that epidurals don't increase the likelihood of cesarean. If childbirth pain is good, it inevitably follows that epidurals must be bad. But as we've already seen, the idea that labor pain is beneficial is a fabrication without basis in scientific evidence. Therefore, there is no reason to feel guilty about pain relief in labor. But what about the side effects? Natural childbirth advocates would have you believe that the epidural poses serious risks to your baby and to you, especially because the drugs will pass directly to your baby once you receive them. Is it any wonder that women feel guilty about epidurals when they are subjected to this outrageous admonition from Judy Sloan Cohane, CNM, a prominent home birth advocate? 2 million American women will take an epidural trip this year during childbirth. Similar to street drug pushers, most anesthesiologists in the delivery room maintain a low profile, avoid making eye contact, and threaten to walk out if they don't get total cooperation. Women get epidurals for one of the main reasons so many women smoked pot in the 1970s. Their friends are doing it. Such a vote of confidence, right? Of course, such claims have no basis in reality. This issue has been studied extensively, and the scientific evidence shows that little, if any, medication in an epidural passes through to the baby during labor. That's just what we would expect based on an understanding of pharmacology and of placentas. Number 1. To get to the baby, a medication needs to get to the mother first. Specifically, the medication must enter the mother's bloodstream. A medication can enter directly through intravenous administration, but if the medication is injected around the spine, only some of it will find its way to the mother's bloodstream. Epidurals are injected into the epidural space around the spine, and that means that considerably less medication ends up in the mother's bloodstream. 2. Dose counts. The effect of a medication depends on the dose. The amount of epidural medication that makes its way into the mother's bloodstream is very small. The amount that crosses the placenta to the baby is smaller still. 3. The placenta is not a sieve. Just because something is in the mother's bloodstream does not mean that it easily crosses the placenta, or indeed crosses the placenta at all. The bottom line is that what gets to the baby is far smaller than the amount of medication injected into the mother's epidural space. Therefore, if an epidural does not sedate the mother, it certainly won't sedate the baby. Alright, I'm going to stop there tonight. I know that was just a quick little read, but I'm pretty tired and I got a lot of stuff to do tomorrow and I've got a busy weekend ahead of me, but look forward to seeing the rest of you later. Good night.